Hello, everybody. I'm Dennis Dominguez. I'm an orthopedic spine surgeon working in, no, it's fine, thank you. Working in Geneva in the orthopedic department. And today it's my pleasure to talk about the fully navigated prone X-lift. So we are talking about Masterclass single position surgery. We will split the session in two parts. The first part is the prone single lateral position surgery, and the second part is going to be one of my colleagues, Dr. Bodom, who will discuss about lateral single position surgery. Okay, so let's start. I will introduce my talk with a case, a practical case. We are not going to discuss about indication, but let's keep in mind that this is a lady. So she's suffering about pain, radicular pain, and low back pain. She has some comorbidities, heart disease, COPD as well, and she's been in trouble, struggling with the low back pain for a while, despite the conservative treatment. So conservative treatment is failed nowadays, and we discuss about surgery. And surgery, what kind of surgery? So we need to solve the L2, L3 foraminal radiculopathy and the low back pain. Let's have a look on the indication of what the problem is. MRI show the foramina stenosis. CT scan show the vacuum sign at the level of the disc, the mobile disc, and some compression. So, and then we need to plan the surgery. We almost use in our practice the EOS. That means it's a full standing X-ray, and with the full standing X-ray, we will have a look on the spinopelvic parameters. And then we see that C7 plumb line. So the lady has some compensatory mechanism. We go for a restoration of the spinopelvic parameters according with the Rusoli types. And this is the formula that we use. So we need to restore the lumbar distribution, according with this graphic, and the spinopelvic alignment. So the apex should be at the level of the L4. For her, is a tiny bit higher, and the apex, the inflection point, should be at the level of T12, and she's actually at the level of L1, L2. So we need to restore that. So on how we decide how to restore the spinopelvic alignment, so we go for whatever planification application. We use SurgiMap for that, and we see again the plumb line, the compensatory mechanism, for example. And the first step is correcting the pelvic tilt. Once we correct the pelvic tilt, we see the right sagittal disbalance that the lady has. And then we say, okay, so we need to plan what kind of surgery we will do. We have been discussing about PSO, about hyperlordotic cages, and I'm going for hyperlordotic cages at the level just above of the construction that the lady has. And we need to talk about hyperlordotic cages in order to correct the spinopelvic parameters and according with the balance that the lady needs. So that was my plan, okay? So, and then I will introduce the fully navigated prone X-lift procedure. We will discuss about lumbar anatomy on lateral approach, or why lateral approach, what are the advantages of the prone lateral approach, fusing the posterior and the lateral approach at the same time, the OR setup, and then some message to keep for home. So I'm not going to describe all the anatomy that we need to know for the lateral approaches, but mainly we need to keep in mind that there is some plexus here, and this is the entry point that papers has described as being the safest entry point for this kind of surgery. We use always neuromonitoring in order to be sure that we are not causing any damage of the nerve root, of the plexus. And then we go for deciding what kind of cage we need to use. And the biggest, the best, the larger, the best, the widest cage, and according with the size of the cage need to be the footprint and the lordosis that the cage needs to be. So in this case, we are going for a X-lift procedure. So literature has shown a lot of information about the fusion rate, amount of lordosis correction that we can get as well. And that is one of the reasons why X-lift procedure or lateral procedures, we can use different type of cages. But what we really need to pay attention is about the shape of the cage. I mean, the lordosis that the patient needs. And why prone lateral position, single position surgery? Because we can combine. We, as a spine surgeon, we used to do posterior approaches. And the posterior approaches is fine, we know, but most of the time we struggle putting cages because from posterior, the P-lift or the T-lift cages are very little cages, and not all of the time we can get more than 15 degrees of lordosis. And we are wondering to put a hyperlordotic cage for this lady. So that is the reason why prone with the lateral position. We will get all the benefits of the lateral position. We are familiar as spine surgeon. We are familiar with the posterior approaches, and we will get the simultaneous approach, the lateral and the posterior at the same time, while we will be able to do the decompression as well for this lady. Why prone as well? Because the prone position will increase the lordosis of the lumbar area, and we will get more facilities to put in the lateral hyperlordotic cages. And the other thing is, paper has shown that in lateral position, the plexus is there. But there is a difference in between lateral position for lateral approaches and the prone position. In the prone position, we see that the plexus is more posterior because of the hip extension, okay? And the peritoneum will fall down because of the gravity. So that are the main advantages of the. This is the OR setup. We will go through all the image afterward in the second presentation. So this is the way how we perform the fully navigated. We have the arrow, the 3D acquisition image, the lateral approach with the holder of the retractor. And then we plan, depending on the type of navigation that you have, you plan how to navigate your instrument. In this time, we use the short track here. We fix on the first dilator for the lateral approach. This is the team performing the two approaches. So, and then is a standard posterior approach and a standard lateral approach as well. And how it looked like with the navigation. So navigation will help us to plan. We will show you after. I will show you after. So we will plan the incision. We plan the size of the cage, the length of the cage, and we know already how to do it. And what we are doing is avoiding all the radiation, because in the pre-day course, I don't know if you were there, we were discussing about how to improve, to optimize radiation in theater. And the best way is fully navigating the procedures. So that is the main reason why we perform that. And then you see here, we have already the posterior screws in. Once the posterior screws are in, we start with the lateral approach simultaneously, while the other team is doing the compression at the same time. So posterior screws are in. We navigated the lateral approach, and then we navigated as well the position of the retractor here. We performed the microdiscectomy, and then the cage. The holder of the cage, we decide the right side of the cage, hyperlordotic cage. In this picture, there is not the hyperlordotic one, but it should be a hyperlordotic cage. And then the cage is in. We are almost ready to publish a paper about this technique, the fully navigated procedure. And at the beginning, to double check and to make sure that everything is fine, because we have to rely on navigation, we perform a CT scan immediately once the cage is in, just to make sure that the cage is in the right position as we plan with the navigation. And that is the final result. So according with the plan, compensatory mechanism, correction of the compensatory mechanism, planning the hyperlordotic cages, and this is the final result with the hyperlordotic cage and normal standard cage. We couldn't move the apex because it was fixed all the level below, but actually what we made the difference is at the level of the inflection point, and this is the X-ray of the lady. So that is the practical case. And not only in sagittal point of view, but in the coronal point of view, we are able to correct as well as in this case, this mild Digen Scully, correction with cages, with hyperlordotic, and we do the correction either in the coronal plane and in the sagittal plane. So take-home message. So why pronix lift? Because we can get all the advantages of the lateral approaches. It's not mandatory, it's not compulsory to do it, but it's a different tool. And as a spine surgeon, as a deformity surgeon, we need to have as much as tool as possible in order to decide what is best for our patient. With the lateral cages, we will increase the lordosis. And we know from the literature, less blood loss, less stay on the hospital, minimizing the risk of the procedure as well, not like a PSO, for example. And we decrease the historical time because we are not repositioning the patient in between the lateral or the posterior. We combine the two procedures. Navigation, the main issue is radiation for the surgeons and for the staff in the OR. So we decrease the radiation to 0, and we improve the accuracy of the implantation of the instrumentation, the implant, actually, yeah. And disadvantage, so hip problem, the hip is extended, so the plexus is more posterior, and depending on the distraction time, what is really important, the distraction time, the plexus could get compressed for no more than 15 minutes. And most of the time, the patient gets with a transient, either sensory or motor problem, but it's transient at least. And according with the literature, it's decreased compared with the lateral approaches, is less than 5% of the time. And the vascular injury, there is some publications showing that there is vascular injury in this position, but it's less than 0.1%. Okay, this is the first step. Thank you.